everyone come on up. We're going to just do a real brief panel section for about 20 minutes or so everyone can get a chance to answer some questions. You guys are going to share one mic, and I'm going to run around, my version of running, with this mic. Jessica.
I was just curious, what work do you do maybe with the inpatient side so that if they are admitted for an overdose, to give them that information to like your clinic, for example, so a little bit more upstream and get that connection?
So I can comment about how our system manages that. So we have our nurse care managers are integrated with our primary care clinics and reach out to any patients that are hospitalized. We also staff our own inpatient service, so our patients will be admitted to doctors that are part of our practice. We also are integrated really strongly with our educational mission, and so all of our residents receive training in addictions treatment, and so when they're providing direct care to the patients are very competent in those areas. And OHSU does have a number of higher level resources, including the Impact team, and that can provide higher level addictions care coordination, including referrals to peer navigators and things like that for coordination of care after discharge. So there's a lot of resources in the hospital that are available, but I'm not sure that's the case for other systems. I can't really comment on that.
Can I actually, just to have a little bit to add to that, so referencing the Impact team that OHSU started a handful of years ago, where they have some sort of roving addiction specialists in the hospital who have been fantastic. CODA's worked with that group and are starting some work with other hospital systems. You know, it's a complicated handoff, but sort of a care transition that we're really invested in, because not everybody who ends up on an inpatient unit for endocarditis is right to go back to primary care for addictions, sort of more comprehensive addictions care. So we've been working on some direct admit pathways from inpatient units to CODA services. So that's an area that we're really excited to develop, and it takes a lot of time at the table, really sort of working that out, but it's pretty important service when we can get it to work.
Physicians who are not psychiatrists, how do they get paid for providing treatment for buprenorphine clients? Because they might have a contract with CareOregon but don't have contract with HealthShare because they're not psychiatrists.
Do you want to?
I don't have a great answer for this. I think it's something that we're continuing to work on, the funding model. And from the standpoint at South Waterfront, which we're speaking to, the experience that Dr. Chang and I had at South Waterfront, we weren't a part of the funding piece of the puzzle. So, but it's continuing to be worked on.
Yeah, and I don't think that we're not getting reimbursed for our visits, though. I think we bill them as standard office visits, and I think they're getting paid for.
I think Jeffrey has something to say about that.
It is a problem, yeah.
So I work at Virginia Garcia, and we're under cavitation, and we've done the math. And every Suboxone patient we bring in, we lose somewhere between $1,000 and $3,000 a year because of the multiple visits we're required to do. We're excited to be part of the fix and part of the solution, but I can't take that to my medical director and say we'd like to take on another 100 patients and lose $1,000 to $3,000 a year per patient, and not be able to get our other patients in. For us to expand, that's it. Number one, number two, number three. If we can't figure that out, we can't do it. And then the other piece of it is opioid use disorder is easier to get people into services. Opioid dependence is not. We have lots of patients walk through on 100 and 200 and 300 milligrams of oxycodone that have been stable for years on that dose. And as we're trying to wean them down, it doesn't happen in primary care. It's too much. We just can't get them there. So getting patients into specialty treatment for opioid dependence has been really a barrier to getting those patients stable and in a functional life in their community. So that's just the 2 points that I've noticed. Those are the two that we're struggling with ourselves. Thank you.
Yeah, I want to add a little bit to what Jeffrey's saying there. That is in sort of thinking back to the how do we change our ideas about when do we initiate treatment, when do we talk about treatment. We've sort of been through this at CODA, and I think there is a real call to us to think differently about what we define as sort of where the need is and when the intervention is the right time. I think when we started primary care collaboration a handful of years ago, we sort of stumbled into just that. I was like, but I'm accustomed as an addictions provider to waiting until like all the sirens are blaring that this person has a substance use disorder before I say, okay, it's my turn. This is my part of the equation. And I don't think we've kind of landed on what the who does what where is, but we have to think differently about that patient population, because otherwise all we're doing is waiting for them to have a serious substance use disorder.
We're waiting for them to fail first.
Right.
Like that's the thing. We even called one of the fellows up at OHSU, and they said, "Well, this patient is stable on their dose. They don't have an opioid use disorder. Call us back
Yeah.
if they fail."
Yeah, we did. That's what we were doing when we started. It was like, but I can't check all the boxes that says this is a problem behavior because they're stable. But we know what's going to happen when they're not, and it's just it's this gray sort of piece of territory that I think we both in primary care and in behavioral health have to just figure out some new boxes.
So I'm not qualified to say this. Is there any pain clinicians in the audience? Sadly, no. So I'm going to step into there. For patients that are on a lot of opiates for a long time for a painful condition, a new thing that doesn't require any kind of waiver at all is to use on-label buprenorphine for pain control because it's safer than the drugs that they're on. I can refer you to people who know more about this than I do. I know about it from seminars and things like that. But again, there are alternatives for those sort of recalcitrant, dangerous to taper, right? Because again, tapering may be harmful to somebody if it leads to other things. Again, we're trying to think about how do we keep people's quality of life and keep them alive. So I'd be happy to help. And then I don't know, I want to dump on Tanya or someone from the health plan needs to answer your question. And I don't think we should just let it gloss over. So this is a CareOregon event. Someone from CareOregon needs to walk up right now and give an answer.
Spoiler alert.
Well, dude, you had me up last. I was going to talk about it. So first I will say I'm Tanya Kapka. I'm the medical director for the metro area here at CareOregon. And full disclosure, Jeffrey and I work in the same primary care clinic at Virginia Garcia in Hillsborough. And we've talked about this a lot for the years that we've been trying to get prescribing started. So the folks who see me on a regular basis at HealthShare and many of the other places where we have these conversations know we are very interested in developing a really good payment model that will allow us to pay for the fact that you need to modify your panel size to be able to see patients who need so many visits within primary care. We know this. We also know that there's sort of this area of overlap where there are some patients who are most appropriate in primary care, some patients who are most appropriate in specialty behavioral health, and then there's all the other people in between, which is probably the biggest group that we're not totally clear on who goes where. I also want to speak to the other thing that, so I'll say something about the payment model in a second. I also want to speak to the other thing about when we're thinking in primary care, if I have somebody with kidney disease, if they have early kidney disease, I'm going to manage them. If they're getting a little further along and I'm not sure and maybe I need to start planning for dialysis at some point, like I have somebody I can call, a nephrologist, and I will call and I'll say, what are the things that I need to do before this person really needs XYZ, and what's the package of things that I need to do now that I can still do within primary care. And then eventually they'll be able to have a consult meeting certain criteria. What we don't have in the metro area right now is a full system-wide set of how we do handoffs between physical health and behavioral health, so primary care and behavioral health. And that is something I would love to see being developed over the next couple of years as we see, which I hope this is a tipping point in this room, but as we see and have more of these conversations, Wheelhouse has done a tremendous amount of work within behavioral health to develop some of those. And in primary care, there's all these hot spots of MAT prescribing, and we just need to meet in the middle in some standardized way. And I think those conversations are really happening now, which is why I'm really excited to be here. Part of that discussion is going to be the payment model. And what is the payment model? Which needs to be paid for by the frustratingly somewhat separate systems we have that we would love to be integrated, and I think everyone in this room would love it to be much more integrated. We are working hard on that, and all I can say is we know that these issues need to be paid for in the right place so that the right patient at the right time can be seen by the right person in a way that's expedient when they really need it. So I hope that's enough of an answer. We know that this is an issue and we're working on it.
Is buprenorphine paid for primarily for pain and by CareOregon, or do you need the opioid disorder?
Let me just.
Buprenorphine is covered for just pain.
If I am a PCP and I prescribe buprenorphine, Jim, tell me if this is wrong, but if I prescribe buprenorphine as a PCP, it'll get paid for, correct?
For pain? For pain?
If I prescribe buprenorphine as a PCP, the medicine gets paid for. There's no PA. Our pharmacy department is here. They can answer that, but I'm pretty sure I'm correct. You can prescribe it in primary care.
Hi, everybody. So I'm Jim Slater. I'm the pharmacy director here at CareOregon, and we do not prior authorize buprenorphine. So what that practically means, the generic buprenorphine, what that practically means is when you prescribe it for your patient and they're going to the pharmacy, we are not checking diagnosis. So this is a very common model, including in Medicare. So if we don't have a reason to check something, then the prescription processes and you're the gatekeeper of what's best for your patient in that regard. So, at least from a CareOregon point of view, now there's all kinds of reasons to get curious together and partner and what's best on behalf of the patient and the evidence, et cetera. But from a technical standpoint, it will just process, if that helps you.
Great, so I was right. Yay. The other thing I will say about the payment model is that integrated behavioral health is something that we do fund, and many of our primary care sites have integrated behavioral health providers who are within the primary care system, and that is something that we are funding currently as part of your physical health plan. We are a physical health plan. We are not a behavioral health plan. There's a lot of confusion about that, partly because we are funding behaviorists in your clinics for primary care, but that is something that we are so committed to doing that we would love for that piece of what's happening in primary care to be much more connected to some of the work that's going on in specialty behavioral health.
I have a question for Amy. I'm just curious regarding statistic. How many overdoses, for example, in Clackamas, you see in 1 month?
Typically on the 911 system, we're typically right around 10 overdoses in a month. The flip side of that, and the part that we're also working on getting connected with, is that the way that we're situated in Clackamas, we have 4 hospitals fairly close together. So we're seeing double that number of people that are overdosing but not using the 911 system. So as we look at our OD map and we look at all of our other statistics that track overdoses, at least half of what we're seeing is from the 911 system, which is what we have access to. The other half are going straight to the emergency department, and I promise you I am working on getting that connection too. There's different HIPAA laws and you have to get buy-in right then. The way we do it now, it comes through our system, so there's no HIPAA issues. The reports can go right to me. If they go straight to the hospital has to get permission from the patient who doesn't really want to interact with them in order for me to be able to get that information to go see them. But we're working on that.
Yes, and another question for you, Amy. So when you see those people who have overdoses, why you can help them just to set an intake appointment, let's say for Central City Concern or for CODA, for people who actually provide buprenorphine treatment in outpatient setting even, because you don't have to wait for residential bed.
So a lot of it's capacity and getting them in. So it takes 3 or 4 attempts even to get into a detox after an overdose. I take people to CODA, DePaul, what's the other one? Hooper, multiple times before they get in. So it's every day, 3 or 4 days in a row, and then they'll get in.
I think just to clarify though, buprenorphine, you can do a buprenorphine induction safely without requiring a detox day. So I think there might be, what Olga's referencing is there might be some lost opportunity, and maybe appreciating where we're working really hard on same day, next day admission in our outpatient clinics. Yeah, so I think there might be an opportunity to connect directly with outpatient providers rather than looking for detox beds or residential beds. I think oftentimes I just find folks who are getting familiar with behavioral health we have this kind of old assumption that addiction equals needs residential treatment, and that there are a number of really effective ways to intervene that don't require sort of 24/7 care. So there's probably more that I think we can connect you to in the community.
Now, this may not be anyone's department specifically, but I'm wondering if anyone's familiar with whether the county correctional systems or the state correctional system has had any thoughts or working towards offering MAT for incarcerated people, or whether there are good connections to patients when they leave incarceration to care in the community.
So Justice 101, which is kind of where I am, is that prison is run by the state Department of Corrections and is typically for people who've been convicted and then sentenced to a year or more. So that's typically months, if not longer, after arrest, incarceration, et cetera. After arrest, at least in Multnomah County, about half the folks are released within 4 hours on their own recognizance. Then they have to come back at a certain date to court. Others stay, but it's an unusual curve in that the average stay is 14 days, but the median stay, if you remember the difference, is a couple of days. So there's a very short window of time. All that being said, the State Department of Corrections this calendar year has taken this on as a project and has begun preliminary things on that. I'm on the governor's task force, and this is a thing that's being pushed for the State Department of Corrections. Again, that's longer sentences, long after initial arrest. The counties in this area, as well as Clark and Yamhill, are also actively working toward figuring this out. The devil is really in the details with the short stays, arriving intoxicated, not quite ready to talk about stuff, and then in the more crowded jails, unpredictable releases that can literally happen anytime during a 24-hour cycle. But the answer is yes, with a bunch of asterisks to follow.
Real quickly, if you would just give a big round of appreciation to all of our presenters.